Hey, everybody. As you know, my name is Shuja Shafqat. I'm one of the PRS resident ambassadors outgoing for this year. So along with my other co-resident ambassadors, Jordan Frey and Chad Purnell, we'd like to welcome everybody to this special PRS Journal Club Live. So for those of you who don't know what PRS Journal Club is, basically every month when the journal comes out, we pick 3 articles to discuss, and we post a podcast, which you can get on iTunes or on YouTube, discussing all 3 articles with a guest moderator. And then each month we have a live Twitter question and answer with that article's authors. So we're doing a live version today with Dr. Osmani and Dr. Cassuto. And so I'm going to start with a brief summary of Dr. Cassuto's article. And his article is called "The Management of Complications Caused by Permanent Fillers in the Face, a Treatment Algorithm." And so Dr. Cassuto is joining us, who's the first author of this article on the development of the treatment and algorithm. So thank you very much, both of you, for being here today. As we know with fillers, most products such as hyaluronic acid are resorbable. However, permanent fillers, both FDA approved and not approved, are still used commonly. Some of the most commonly encountered complaints are complications such as tedious, long-lasting, non-resolving inflammatory reactions of different grades, including nodules. The incidence of nodules is reported to be between 0.01 and 1% of such procedures, and is likely underreported given the large number of patients undergoing this, which is clinically significant. And obviously, these lesions are challenging to treat.
So thanks, Shuja. I'll take over briefly with kind of the methods and techniques. So 219 consecutive patients who were referred for these inflammatory reactions to permanent fillers were reviewed. And all patients had physical and ultrasound examinations to define the injection distributions, either cystic or infiltrative. And briefly going over the operative technique, basically this was an intralesional laser treatment procedure consisting of percutaneously inserting a 200 micrometer fiber optic 808 nanometer diode laser into the lesions and drilling several small holes. There's no anesthesia typically necessary, and on manual palpation usually revealed a softening of the deposits as the immediate clinical endpoint. And at this point, the heat liquefied materials were evacuated by finger compression through the skin entrance point. And if clinical and ultrasonographic picture was consistent with a cystic implant, a stab incision with an 11 blade was also utilized along the relaxed skin tension lines. And in these cases, the fiber optic was then introduced through the stab wound incision, and the implant was irradiated uniformly with the laser.
So just to briefly go over the results. So the average lesion required about 1 to 2 treatment sessions, so a mean of 1.7 sessions per lesion. And the complete disappearance of the lesions was obtained in about 62% of cases. And so partial improvement with greater than 50% reduction was obtained in 30% of cases, and then 8% of patients discontinued the treatment because of a lack of satisfaction. So there were some complications. These included transient swelling in almost every case, hematoma in 2%, secondary sterile abscesses in 9.5%, and minimal scarring in 10%. So that's it for the summary of our first article. So we'll just move straight into an intro of our second article. So the second article we're going to be discussing today is going to be detection of perforators using smartphone thermal imaging from Drs. Hardwicke, Osmani, and Skillman from the United Kingdom. So today we have the honor of being joined by Dr. Omer Osmani right here live to discuss this article that won Best Ideas and Innovations. And remember, you can download all of these month's articles and read them for free on PRSjournal.com, including an archive of all the past Journal Club articles. So just a quick intro. Thermal imaging detects infrared radiation from an object. It produces an image based on the local temperature, and this can be used as a surrogate marker for cutaneous blood flow, which brings warmth with it. Thermal imaging has been applied to many areas within burns and plastic surgery already. So this includes detection of cutaneous perforators and assessment of burn depth. However, the high-resolution infrared cameras that are used, they are extremely expensive, and so this can preclude widespread use. So in their study, they used something called the FLIR-1, which is a lower-resolution, smartphone-compatible miniature thermal imaging camera that retails at under $200. So I'm going to kick it over to Shuja to talk about their methods.
Thanks, Chad. So in a proof of concept study, the patients and healthy volunteers were assessed with thermal imaging for detecting and mapping perforators, defining perforasomes, and monitoring of free flaps. 10 healthy volunteers were imaged at a distance of 70 centimeters, allowing 3 minutes after clothing removal for acclimatization with the surrounding conditions. Multiple abdominal cutaneous perforators were signified as hotspots on the thermal images. They were identified and subsequently aided handheld Doppler ultrasound localization. In addition, for identification of perforators for ALT flaps, the hotspots were consistent with the known anatomical landmarks. Intraoperative perforasome imaging was performed in a 55-year-old woman, which you can see in the article, who is undergoing a right mastectomy with immediate DIEP flap reconstruction. And I'm going to kick it over to Jordan for the ending.
Thanks, Shuja. So Dr. Osmani and the authors highlight that once the flap is raised on a single perforator, one can see that the tissues are perfused by this perforator. And in the postoperative period, thermal imaging was also used as an adjunct to clinical free flap monitoring, with a thermal image showing both hotspots at the site of the skin paddle and cutaneous perforators to the mastectomy skin flap. So in conclusion, although the resolution of this device is lower than that of more expensive thermal imaging cameras, it provides a low-cost alternative that can be applied to other areas of burns and plastic surgery. So I think now what we're going to do, we'll open it up to a Q&A for both papers. And I'll start with a question for Dr. Osmani. So since writing this paper, how have you been using this technology clinically? Has it expanded? Has it been refined? What's kind of been going on?
First of all, I would, on behalf of all the authors, I would like to thank all the readers of PRS who have read and downloaded our article to make it come to this stage and get us the prize for ideas and innovation. Answering your question, at the moment, as you know, this was all an experimental kind of study. To move it ahead, what we are trying to do these days, everything is about not static, but everything is about dynamic thing, So what we are trying to do is to compare the hotspots that we get with the thermal imaging camera with an MRA angiogram, which shows the flow velocity of individual perforators that show up as hotspots in the thermal imaging. We just want to know, by using this, whether the hottest hotspot is actually the best flow perforator. And if we can tally this two together, then I think with a combination of MRA's flow velocity scans and the thermal imaging camera, you can accurately pick the perforator that you want to base the free flap on. Because these days, I think the whole idea is to try and find a perforator and create a flap. There is no boundaries as to what sort of flap you can create as long as you have a good perforator. So that's what we are looking into at the moment.
Great.
So I have a question for Dr. Cassuto. So this is a great way to treat these complications, but is there a good way to prevent this type of complication and inflammatory response from a permanent filler?
Yeah, that's an excellent question, and actually prevention is always much better than treating the trouble once it has come. The best prevention would be not to insert a foreign body in a patient unless you can be sure that in case you need, you can remove it very relatively with ease, as we do with breast implants, for example. It is obvious that as soon as you inject something free into tissues without a distinct anatomical compartment, then once you need to take it out, you're not always sure you can do it. And forgive me for not being humble enough, this comes from someone who has found a way to remove it. Even I would not dare injecting something that cannot be dissolved. And now I am talking about both resorbable and non-resorbable permanent fillers. Even resorbable fillers that you cannot remove or dissolve immediately, I would be very, very cautious in injecting them.
Thank you. I think at this point we're going to open it up for questions from the audience and also questions from Twitter and Facebook, if any of those questions are coming in. Anybody in the audience?
Iris Savetsky from NYU. I really enjoyed both of your papers. Dr. Osmani, do you think this is a tool that nurses can be using down the line to help monitor free flops in the postoperative period?
The answer is no and then yes. I think the first no is because to prove that there is no adjunct or substitute for a proper clinical evaluation of a flap, or if you're monitoring a free flap especially, I think I would still stick to the old ways of doing things, of checking the color, the blanching and everything. Yes, this is another tool which can be used. I mean, nowadays on the wards, different hospitals use different techniques of monitoring flaps, which is done by nursing staff. Some places use the ear thermometers to see the temperature differences. Some places use just Doppler signals. All these have positive and negative features, and you get false positive and false negative readings for everything. All these tools. So this is a very initial kind of experimental stage. As and when I think we are more comfortable and the nursing staff is more comfortable in using the camera and actually interpreting how to read the images, I think it will be a little bit of learning curve before it turns to be a yes. So that's why I'm a bit careful in saying yes straightforward.
Thank you. And Dr. Cassuto, what other modalities have you used, and is there any role for intralesional steroids?
Okay. I am a bit controversial on that because I still have to find someone who can give us a logical reason to use steroids in case of this kind of inflammatory complications. And this is because under the excuse of evidence-based medicine, basically too many have been copying and pasting stuff that was published in the past, generally speaking about complications of some fillers, but without giving a rationale. So yes, you can use aspirin and steroids and anti-inflammatory drugs on any kind of infection. Does it really make sense today? I would like to point out that, and this is, many of my friends are dermatologists, but I have trouble convincing many of them. I think it's the only specialty left that still treats foreign body infections with steroids. You look into any other surgical or medical specialty, whenever there is an inflammation around a pacemaker or an orthopedic implant or a breast implant, we treat it by removing the foreign body and with antibiotics. Now, with these fillers, it seems very difficult to do it. So instead of removing it, they can't. They use steroids. And instead of giving antibiotics, they still give steroids, either locally or systemically. Now, I started this procedure in 2006, thanks to the intuition of a colleague that is no longer with us, Dr. Marangoni from Italy. And I started because I was referred a patient with osteoporosis after years of steroids because of pain facial granulomatosis. And basically the article talks about nodules, but some of those patients that raise the amount of necessary treatments, they just have moon faces that cannot be treated otherwise. And so I had to find a more logical way. So the more logical way, whether you believe in biofilms or not, is try to remove the cause, which is eventual contamination by bacteria and the foreign body itself. Just trying to turn the fire off with steroids any way you give them, or now I hear about 5-FU. There is a Spanish hypothesis of giving them cyclosporine. Can you imagine that? I leave it to you to judge.
Great. Thank you very much, Bo.
Hi, I'm Aaron, managing editor of PRS, but I'm reading questions off of Twitter. So Sammy on Twitter says to Dr. Osmani, could you imagine a scenario where patients use these devices to monitor free flaps from home?
Again, I think my answer will be similar to what I said earlier. Especially in UK at the moment, the way we monitor free flaps is by keeping the patients within the hospital and not sending them home immediately. I think usually the hospital stay is a minimum of about 3 to 4 days. Well, it obviously depends on what sort of free flap you have done. To answer your question accurately, I think at the moment, this is not the time when we ourselves are kind of experimenting. We are not sure how reliable and how effective the monitoring is of free flaps. Maybe in future, as more and more people start using it and it becomes easier, maybe it will become like something like a insulin pen, which patients carry around. So they might have this little thermal imaging camera, and they kind of check it every half an hour, or whatever, and then they tweet you a picture saying, this is the state of the flap, what do you think? So I think it's all about time and progression, and with time, I think the more we learn about how it behaves and how we can use it, maybe there is a scope in somewhere in future where it can happen, but I think again it's all kind of a guarded approach rather than openly saying, oh yes, you can just use it as and where you want, which I think would be wrong.
Great, thanks. Dr. Cassuto, I have a question for you. So here in the U.S., people don't use a lot of permanent fillers. So we're mainly injecting, hyaluronic acid and things that are dissolvable. So I wanted to know, how is your paper relevant to practitioners in the United States? How can we use your results?
Oh, that's a very important point. Even though you have here a lot of limitations as far as the range of injectables that are available, this is still one of the few countries in the world where the local authority, in this case the FDA, either allows or tolerates the injection of permanent fillers. Back in Europe today, it can be done underground, but legally, just by injecting one of them, even without complications, you can get into serious trouble because they have been banned. And so I see the American population at the moment as much more exposed. And I do start seeing American patients that come overseas. And it's a bit discouraging because on one hand they feel kind of betrayed by the medical category here. Because everyone told them that this was safe, and the 5 years data about safety are extremely satisfactory. And how comes that once I have a problem, nobody has the guts, forgive me, of dealing with it? Now, I'm not blaming anybody, but my paper wanted to answer this kind of need very humbly. What I can add is that I have treated more than 400 patients by now. The numbers in the paper are not updated anymore. And even on a larger sample, plus another almost 300 patients paper that has been submitted by my Dutch trainees that confirms the same experience, is encouraging. That means that those patients can be treated without surgery. Now, we're all surgeons. What's so good about treating them without surgery? Now, your generation probably will be better at understanding this than mine. Most of these patients probably have biofilm, even though this is very difficult to prove. Now, the surgical criteria for a biofilm-contaminated foreign body should be oncological. You should do very wide excisions, which for a half an inch inflamed nodule on the face seems an absurd. But that's the only chance you have to solve the problem. Now, I'm throwing another controversial way, but I've only done this on a very few sample, and it's just a preliminary experience. If you do treat with the right antibiotics, and the right combination has been published on PRS several times, a macrolide and a quinolone, but you do it for months, then you can remove it surgically with an excision that is not very wide, exactly the way oncologic surgeons do give chemotherapy to reduce the tumor, and then from non-operable it becomes operable. So in case you don't want to bother and come and learn this little laser procedure, I'm offering you this as an alternative, though obviously it's much more invasive. Remember that you're dealing with patients that fail to make the switch from the cosmetic to the pathology. So all they know is that they went in to remove wrinkles. All of a sudden, they find themselves suffering from a disease. They still have the requirements of a cosmetic patient. And that's the hardest part of treating them.
For Dr. Osmani, what do you see as kind of the next step in the progression of this this method, and what do you see as the future of thermal imaging in microsurgery and flap surgery?
Interesting question. I think when you compare, there are some fascinating equipment here in the exhibition which cost over $100,000. I think when you consider the cost to benefit ratio, the FLIR one is, I think they have recently launched a new model with higher resolution. It's called FLIR 1 Pro, which I think retails around $400. If you can buy something which you can carry in the pocket, and especially in a busy center where lots of free flaps are done, or even for burns for that matter, if you want to evaluate the exact nature of the burn, you might not be able to say the depth, but if you want to see the character of the burn, then it is a very useful tool to just take it out of your pocket, do the image, and see what sort of vascularity is there in the tissue. I think as plastic surgeons, we are probably one of those few surgical specialties who care about small blood vessels. And if you can monitor, things like perforators using thermal imaging, using this device, then I think the uses and where it can be, the indications, so to say, would be pretty much sky is the limit. If you can imagine a new way of using it, you can go ahead and try it. So I think the scope is vast. It is just, I think, what we have shown is there is something out there in the market which originally belongs to the builders. It's for the buildings where they check the drafts and stuff like that. But you can use that device to in your medical practice, and it's quite effective.
We have one more question off of Twitter. This is from Amanda. It's for Dr. Cassuto. It says, do you see the role for this technique expanding to untoward injections in other areas of the body?
Okay. That's a very challenging question. I'm not very good at telling the future, but the present is that there are too many people in this world today, and in this country too, walking around with these implants, with these permanent materials inserted somewhere. And remember, it's not only in the face, unfortunately. We do see people with gluteal calves and other kinds of augmentation done with all sorts of materials. Remember also that in our global society today, traveling to other countries where any crazy material is available has become even easier. So unlike resorbable materials, these materials stay there for decades. Unfortunately, even if theoretically tomorrow morning they were all banned, your generation is still occasionally going to see these people when they get into trouble. These materials can get infected anytime, even after 20 years, number one. Number two, we all know that our faces age by shrinking, by losing substance and quality of substance. So whenever these implants are there, the face ages around them, and these implants after a while start sticking out. And those are very, very difficult to correct unless you excise them, and then we're back to square one. People want to be beautified, quote unquote, and we put more scars into their faces. It doesn't meet their expectations. It doesn't make sense. So my prayer is before, as our colleague was suggesting, before you take out your syringe with steroids or 5-FU, or before you prescribe steroids, please go back to the algorithm, and you will solve most of those cases without inflicting further damage. If you end up in that algorithm in one of those boxes where the laser treatment is necessary, then at the moment, besides our 2 centers in Italy, I have trained people in a center in Holland and in Spain. And training is free for any American colleague who wants to learn this procedure. If we train you, it's very, very easy. Both the device and the technique are FDA approved. So the only problem would be that you need the courage to treat someone who's very unhappy and is probably going to sue people. I can tell you that out of the more than 400 people I've treated, I was not involved in a single lawsuit, and 90% of those cases sued the doctor who injected them. So I think that even though the legal system is a bit crazy, but patients know when you're just trying to help them. And that will keep you safe. Please do not be afraid.
So if we don't have any other questions, I'd just like to thank Dr. Osmani and Dr. Cassuto for sharing their wonderful papers and their knowledge with us. So just another hand for them, please.